The two midnight rule has been around since 2013. It's hard to believe that we are almost 12 years in. And I do want to point out that there are three components to the two midnight rule. Sometimes we get lost in that first part, which is the two midnight expectation. So there's the two midnight expectation, which is that generally a claim is payable by Part A if the admitting physician at the time of admission thinks the patient is going to require medically necessary hospital care that is expected to pass two midnights. They don't have to pass two midnights, and we can perhaps get into the nuances of that, but it's just the expectation that they will pass two midnights. The second component is the Inpatient-Only List. There are certain CPT codes that translate into ICD PCS codes that CMS says because of the intensity of the procedure or the amount of resources required to take care of that patient, regardless of the length of stay, those claims should be Part A reimbursable. And then the final one is the case-by-case exception, which is if the admitting physician feels that this patient is probably not going to stay two midnights, but because of the complexity of their issues, the intensity of services, a good example may be a DKA patient that's going to require maybe some ICU care, insulin drips, a lot of frequent checking of labs, but sometimes recover very quickly. But those still should be inpatient. And there's some unforeseen circumstances and other things that we could talk about, the nuances that would truncate that stay that was unforeseen. Patient has to transfer, they leave AMA, et cetera. I think the significance, obviously, in UM is that it affects whether you're going to have a DRG reimbursement or an APC OBS outpatient reimbursement. And as we know that those DRGs, for the most part, are reimbursed at a higher level. So the revenue associated with that is going to be better for the hospitals for DRGs. The other thing is like value-based purchasing that has, the readmission penalties and other things are only associated with inpatients. So if a patient is admitted as an observation, they don't count towards the value-based purchasing or the star ratings. And then, of course, there's the audit risks associated with these short stays, meaning they're less than two midnights. So if a patient comes in, there's an inpatient order, the hospital drops a claim for a patient that did not stay two midnights past that inpatient order, there's at least some potential risk associated with that from a compliance standpoint. And CMS has a lot of mechanisms to look into that. The MACs, the RACs, the Target, Probe, and Educate, and even you can use the PEPPER to see if you are you're an outlier, the use of the two midnight.